Good afternoon all. The topic for my paper presentation is postoperative cylinder on using conventional keratometry versus total keratometry for IOL calculation. So corneal power is one of the critical variables for predicting postoperative refraction, where IOL master 700 uses telecentric 3-zone keratometry to calculate the anterior corneal surface, and when we combine the above mentioned method with pachymetry, which is obtained using step-source OCT, we get the posterior corneal surface. Total keratometry is obtained on combining the anterior and posterior corneal surface measurements with the corneal thickness using the thick lens formula. So aim of the study is to compare the residual cylinder after 1 month of cataract surgery with toric IOL implantation following IOL power calculation using conventional keratometry and total keratometry. This is a prospective study conducted at the tertiary eye center. The study duration was 1 month and we conducted the study on 60 eyes of 45 patients. So the inclusion criteria is axial length ranging from 22 to 25 millimeter, K reading of 40 to 49 diopter, all the uncomplicated cases, and patients whose biometry is obtained using the optical biometry, and patients in whom toric access of IQ or eye-hands IOLs are implanted. And the exclusion criteria includes prior ocular surgery or any ocular injuries or any other comorbidities in the same eye, any visual axis opacities, or any patients who fail to follow. So after noting all the basic demographics, we have divided the patient into two groups. One is conventional keratometry group, where we calculate the IOL power using Barrett universal 2 formula. Total keratometry group, where we calculate the IOL power using Barrett TK formula. So all cataract surgery were performed by a single surgeon using MICS technique, and we have used Alcon Centurion or J&J Veritas phacoemulsification machines, and the IOLs implanted were Acrysof IQ toric and eye-hands toric IOL. So the data was collected at pre-op and at 4 weeks post-op. Uncorrected and corrected distant visual acuity was measured. Refraction, intraocular pressure, and strictly biomicroscopic findings were noted. And coming to the statistical analysis, these were the statistical methods employed, and a p-value of less than 0.05 was considered statistically significant. Coming to results and discussion, when we look at the age, it was around 69.2. It was 69.2 in case of conventional keratometry and 65.8 in total keratometry. There was no significance between the two groups in case of age, and we can see a male predominance in case of conventional keratometry group and a female predominance in case of total keratometry group, which was also not significant. And eye laterality was observed in between the two groups. It was well balanced, which minimizes the confounding from anatomical variations. Axial length, when we look at the axial length between the two groups, it was comparable, and same goes with the flatter meridian of K also. When we look at the steeper meridian, there is a slight difference, but it was not significant, and we can see a lower variability seen in case of TK group in flatter meridian and steeper meridian. When we look at the corneal astigmatism or the corneal cylinder power, it was 1 diopter mean in conventional keratometry group and 1.67 in total keratometry group, which was statistically significant, which implies that conventional keratometry may underestimate corneal astigmatism, which potentially leads to less accurate toric IOL selection. Coming to measurement of total toricity of an IOL, that is IOL cylinder power, we can see a higher IOL cylinder power in case of total keratometry group compared to the conventional keratometry group. We can see a 20% increase in the calculated cylinder power, but it was not significant. If we look at the predicted postoperative cylinder, it was minus 0.05 in case of conventional keratometry group and minus 0.1 in case of total keratometry group, which was significant. We can see TK exhibits a modest but significant more predicted cylinder than conventional keratometry group, and this highlights the difference in the assessment of astigmatism, and an increase in the astigmatism detected has implication for toric IOL selection and the management of astigmatism. The same goes with the study done by Hofer et al. In 447 eyes, and also in a study done by Kim et al. On 91 eyes. When we look at the postoperative cylinder in subjective refraction, this was the double angle plot. This explains that mean was higher in case of total keratometry group. We can see a slightly larger variability also in case of total keratometry group, and mean absolute cylinder both were low, but K group is slightly closer to the plano cylinder. When we look at the centroid, both were near zero, which indicates the minimal net astigmatism, and 95% confidence interval ellipse diameter, we can see a wider confidence ellipse in case of TK group, which indicates a greater dispersion. So both total keratometry and conventional keratometry has performed similarly, and there was no statistical significance between the two groups in case of postoperative cylinder in refraction. And TK group, since it considers the anterior and posterior corneal surfaces, theoretically it is more accurate estimate of total corneal astigmatism, but greater variability is seen in case of clinical measurements. Since there is small difference in the variability, unlikely to impact the visual satisfaction, so it supports the continued use of either method and underscores the reliability of both keratometric approaches in achieving precise refractive targets. This goes with a study done by Van et al., where both K and TK values do not significantly differ in healthy eyes, and clinically relevant differences impacting the IOL power calculation were rare. The conclusion is, using conventional keratometry and sending it through a Barrett Universal 2 formula is a better way in taking care of postoperative astigmatism, as we have already found, than using the total keratometry and sending it through the Barrett TK formula. And also we have found that total keratometry offers significant advantage in astigmatism assessment and predictive accuracy for postoperative refractive outcomes. The limitation of the study was small sample size and shorter duration of follow-up. These were my references. Thank you. Yes, sir. When we look at the postoperative residual cylinder, it was more in case of TK group, but the difference was not that significant among the two groups. But when it comes to the prediction of the postoperative cylinder, TK group is having more predictive accuracy compared to the conventional keratometry group. So most of the premium IOS are need a measurement of the posterior corneal astigmatism also, so that it would be better to take the total cornea, total keratometry for measuring the by measuring the corneal astigmatism and predictive accuracy of the cylinder.
So, sir's point is, you said your conclusion, na, both the methods are at par. Sir is asking, why should somebody go for the total case? Both the methods are at par.
Because of the predictive accuracy of the total keratometry, we can
So you
go
can
for
say there was a trend, right? There
yeah,
was a
there is
difference, but that was not reaching the statistical
significant.
significance. So if you take larger numbers, say 300 in each group, then you may get some significant difference. So in your limitation, you should add that. There is a small sample, there is a trend, but we didn't find any statistical significance in differences. So which device you use for TK?
We use IOL Master 700.
And for conventional?
IOL Master 700 only.
Okay. You use the same device for both. So see, the results are predictable because in a normal cornea, normal corneas, the posterior corneal curvature has very less contribution to the total corneal power. Your study just supports that finding. If you take extreme levels, suppose you exclude 43, 45 and take below 42 and above 45, then your TK might have been more useful in predicting error compared to normal case.